Welcome. I'm Dr. Danielle Plummer and want to thank you for taking time out of your day to learn how pharmacists can help improve hyperemesis gravidarum outcomes. So just a little bit about me. I got into this because I'm a pharmacist and a three-time survivor of hyperemesis gravidarum. And it was in pharmacy school that I learned about ways we can treat people who cannot eat and have treatments for malnourishment when I was left to suffer for 27 months of my life, literally 3 pregnancies, in a state of malnourishment, and told there was really nothing that can be done to help me. Learned as a pharmacist, there absolutely is things that can be done to help you. A couple of years ago, I became a certified doula because I wanted to learn how to support pregnant women in a capacity beyond medications. I became certified in pharmacogenomics and do pharmacogenetic personalized medicine because so many of the medications we use for hyperemesis to stop the extreme vomiting have genetic variations. And then 2019, I started a blog as HG Pharmacist, which recently rebranded into obstetrics because I do personalized medication for many diseases throughout pregnancy and not just hyperemesis. Just want to be clear, everything I say today are my own views through my education and experience and not correlated or supported by any organization from which I work or volunteer. Goals for today is to learn what is hyperemesis gravidarum, what definition, how do we define it, how to diagnose it, understanding what medication options are available, and how to create a supportive environment in your pharmacy so that these women, when they come in for help and support, you're able to ask their questions and know that there are treatment support available. But before we get started, take a moment, think about all the things you like to do. It's summertime right now while I'm recording this, so we go to the beach, we eat, we drink, we spend time with friends, family, and if we have other children, each moment is so precious to spend in them. Now imagine something happened overnight. Suddenly you can't eat anything. Everything you try to eat comes back up. Drinking, you can't even keep down water. The thought of going to the beach, a distant memory. And spending time with children, taken away from you. So why should pharmacists care? Because we are perfectly placed to support these pregnant women. They are a whole in healthcare. When you become pregnant, traditionally you don't see an obstetrician until you're about 10 weeks along. That sends women with hyperemesis and other disease states in early antepartum care going to the emergency room. That is not the place to treat a chronic condition for somebody who's not contagious. Though if it's not treated early, could be life-threatening. So take what you learned today to help improve maternal morbidity and mortality due to hyperemesis gravidarum. I want to take the example, 3 women here. On the left, we have Maria, happily married, pregnant with twins, super excited to start a family and grow her family. In the middle is Elise, who is an RN and now a blockchain strategist. And on the right, Jessica is a teacher and very into fitness. So these women all became really sick during their pregnancy. How do we define them? The majority of women who have hyperemesis gravidarum do not get a true diagnosis. What it is, what definition I like, was founded by the Her Foundation, again, hyperemesis.org, a potentially life-threatening pregnancy disease that may cause weight loss, malnutrition, dehydration, and debility due to severe nausea and vomiting. There are these long-term effects from having dehydration, electrolyte disturbances that require nutrition to be replaced, potentially to the point of having parenteral nutrition. It's just vast what malnutrition can do to a body at a time when you're supposed to be glowing and optimal nutrition, not just for yourself, but for the fetus growing inside of you. But in this disease state, it is a disease of malnutrition that may last up to the full 9 months, and the potential complications for both mom and baby may last a lifetime. Note that there is no cure, no FDA-approved medications, and no standardized effective guidelines for prevention, treatment, or recovery. And while we do have some in the works in the progress, it's going to be time to get into the hands of the clinician and the patient. So that was from the Her Foundation, their definition. 2 years ago, a group of stakeholders got together in Windsor, England, and put together this definition to help be more inclusive of who is getting the right diagnosis. So it starts early in pregnancy before week 16 of gestation, characterized by severe nausea and or vomiting, inability to eat or drink, and strongly limits daily activities of daily living. And that's going to be more inclusive. There's a lot of women who have extreme nausea for the whole pregnancy, they lose their job. They have a lot of the same consequences, but they're not diagnosed because there's no emesis. While we're talking about definitions, just want to refresh, what is a teratogen? It's a medication or agent or factor known to cause birth defects. Safe for safety, will not cause birth defects. But keep in mind, this does not talk about the adverse effects to the mom. So is something effective or efficacious, or does it have efficacy? Does it work? Something may be not a teratogen, may be safe in pregnancy, but is the mom getting any benefit from it? Or are the adverse effects outweighing the benefits that they're getting? Note that in 2015, the FDA did change the way medications are categorized. Those from prior to that time are grandfathered in. And I haven't gotten feedback yet on this new, not even so new anymore, 8 years of pregnancy and lactation labeling rule. I'd love to hear back. Reach out to me on how that's working, if anybody's using it, because it's been really quiet in my circle. But just again, keep in mind, no FDA-approved medications for hyperemesis, one FDA-approved medication for morning sickness, diclegis, Bogesta, extended release forms. Whether they work or not, again, conflicting studies for efficacy. I want to do away with some old wives' tales. So what is hyperemesis? What is it not? It is definitely not morning sickness. There are scales that can compare it to. I'll get into diagnosis in a moment, but it is a spectrum. And sometimes it's not always black and white and easy to say. That's why I like that Windsor definition that is showing, hey, what is happening to their activities of daily living? Listen to that mom. It does not always suddenly disappear at 12 weeks. This old wives' tale needs to go away. Yes, it might help in some women. They start to feel better, but that is not a blanket statement, and it cannot be told to everybody. Sometimes 15, sometimes 20. In many women, it does last the entire pregnancy. And these really old wives' tales, because the mom doesn't want to be pregnant, not a woman seeking attention. And it is not caused because of a mental health condition. However, when you take away a woman's ability to eat, to drink, and to exercise, guess what will happen to their mental health? Definitely need support in that area. Some fast facts, up to 10.5% of all pregnancies. So think about 3.6 million pregnancies in the United States. That was about approximately in 2019. If we're looking at 2%, it said on major medical health websites, rare disease, up to 2% or 1 to 3%. We're looking still at over 75,000 pregnancies. Now, if we think about that, look at this statistic here. Up to a third, about 34, up to 34% do not make it to term because of miscarriage, choice termination, because they've lost their job, their organs are failing, and their own life is at risk. And that, when we say make it to term, I'm not talking preterm, I'm talking to have the delivery of the baby at all. These women suffer so terribly through job loss. It's not just their immediate pay. You're looking at lifetime 401k matches, bonuses, advancement in their careers. They're going to these emergency medicine visits over and over and over. Again, from a few years ago, 375,000 visits at a cost of $2.5 billion annually. In this time, since that statistic was done by the Her Foundation, I'm sure it has astronomically increased and is a leading cause of antepartum maternal mortality, early pregnancy mortality. This is a serious disease condition with potential complications that are vast. This is due to that malnutrition, the dehydration, the electrolyte imbalance, and may have long-term effects in the babies as well. What is the cause? If you take away anything from this information session today, please remember the GDF15 gene. In fact, Dr. Marlena Fejer with the Her Foundation and USC had told me that it's higher in women with hyperemesis than it is through patients having chemotherapy due to their cancer treatment. So let that sink in. These women are really, really sick. There's a genetic cause behind it. We don't yet have a diagnosis for this gene. We don't have a targeted therapy, but keep in mind, it is not related to the steroid hormones, progesterone, estrogen, cortisol, and it is not the HCG gene that is causing the vomiting. So if we take those away and we look at these other possible causes, there are connections, because we know that gut health is so important. When you look at GI dysfunction, when you look at inflammation, autoimmune disorders, the thyroid disease, how our thyroid works, it has the same alpha subunit as the HCG on the HCG receptor. This comes into play, but it's the GDF15 gene that is causing this. And they published their work at ACOG and SMFM this year in 2023. And it's really nice to let these women know, hey, there's a genetic cause behind it. So just so grateful for this work. looking forward to diagnostic testing for it, this GDF15 gene, and targeted therapies. How do you diagnose a patient with hyperemesis gravidarum? Most women are told, oh, it's just morning sickness. It'll go away in 12 weeks. So yeah, it's okay to like be left malnourished and dehydrated and have these vast complications that, if not treated early, will escalate into other problems, potentially mortality. So let's take a look at the mom. And this is where that Windsor definition really becomes important. Subjective, right? We use SOAP notes in the clinical world. So subjective, we want to look at how often is that mom vomiting? How long has that been going on? Have they lost weight? And it goes back to that activities of daily living. I just meet so many moms who can't even get out of bed to go to the bathroom to be able to vomit, and they have to keep that bucket near them. How long can that last? You're going to get your muscle wasting. You're going to have so many problems from that. Have they lost days of work? What have they tried and failed? Do they feel dizzy, tachycardic, thirsty, starving? Are they getting any nutrition at all? What are they vomiting? Is bile coming up? Is blood coming up? That prolonged fatigue, brain fog, depression, let's treat the cause and not medicate the symptoms. How do we diagnose this objectively? We have lab tests. Look at the lab tests and tell them to get a thorough panel. We're going to look at our electrolytes, our potassium, our magnesium, our sodium. If they're depleted, get them replenished carefully, slowly, right? Glucose. I met a mom once who was on metformin for prediabetes prior to becoming pregnant. Couldn't take the metformin because she can't keep anything down. When she went to the emergency room, her glucose was at 55. So good thing she wasn't taking her metformin, right? Could have been dangerous. And this is where pharmacists can look at the medications, what's going on with that patient, and say, hey, let's tweak this for your own safety. Never use a diagnostic test one alone to diagnose a disease, right? So many women will go into the emergency room, they'll get their ketones measured, be told, oh, you don't have ketones in your urine, you don't have hyperemesis. It's so much more than that. And that's where, again, this Windsor definition, the subjective is so important. I like to tell women, if you know you've had this before, you want to have more children, get baseline on these. What is your thyroid prior to becoming pregnant? So you know that you're in good shape heading into this. Weight loss is often a used measure, but again, very subjective. I've met so many women, if you're overweight or obese to begin, you get pregnant, they're told, oh, it's good you've lost 20 pounds, you're healthier. And they're not addressing the issue that these women are malnourished, they're starving, they've lost their jobs. So something along those lines to put a complete picture, subjective and objective, to create your assessment and your plan. And when you go into the hospital, we're going to look at the hypovolemia and treat that there. Really important to align these goals. So from the clinician's perspective, what are we looking for? We want that mom to get the right diagnosis, not something that might be done in an outpatient pharmacy, but you can tell that mom who's coming into your pharmacy for her diclegis or for help, maybe even wristbands, ginger, crackers, all these things that are not going to help a hyperemesis mom. They've tried that. Might help your morning sickness, mild sickness patient just get through, but not a mom in this condition. So tell her, hey, I think you might have hyperemesis gravidarum. Go talk to your clinician about that. And the light bulb will come on and they go, oh, there's a name to what I'm experiencing. We want to stop their vomiting and at the same time replenish their nutrients and keep those nutrients going optimally through the pregnancy. Everyone wants to stay out of the emergency room. This came to the forefront during COVID pandemic, of course. We don't want to be around contagious people. And when I talk to emergency medicine doctors, they said, I have so many of these women in my hospital, my ER. They're taking up beds for my stroke, my heart attack patients, even gunshot victims, right? How do we both agree, women don't want to be there. The clinicians don't want them there. Let's do what we can from an outpatient's perspective to prevent them from going to the emergency room. And what does the patient want here? They want to be able to eat, to drink. They are so afraid to take medications for good understanding, right? Good reason. So calm their fears and talk to them about the medications that they are taking. Show them the studies that they've been used in pregnancy, or caution them. Maybe they're going to go take something over the counter, which may not necessarily be safe, even if it's not a teratogen, might not have the best effects for the mom or mother. Will the efficacy outweigh the adverse risks? And that's where you are in the perfect position to have these conversations. They want to know their baby is safe and they want to improve their quality of life so they can get back to work and spending time with their friends and family. So goals for an outpatient pharmacy: help your patient understand what medications are safest and most effective. Look at the drug-drug interactions, look at your drug-disease interactions, look at the dose, the duration, the formulation, the route. The chart on the right here has medications other than oral. There are a lot of them. They might be oral disintegrating or dissolving, right? But we can also look at topical options or vaginal or rectal or sub-Q, or if they have to, then IV, of course. So we want to get them that nutrients, decrease their vomiting, increase their quality of life. What medications are most affordable? This is where you can have a tremendous positive impact on the financial health. Remember that $2.5 billion? There's a lot that goes into that. I see prescriptions so many times where a mom will go in to the pharmacy, pharmacist tells them, hey, it's been denied, without offering, going, you know what? The 8 milligram ondansetron is crazy expensive or denied, or your granisetron patch Sancuxo is denied, but we have alternatives for you. Maybe that 4 milligram, or your metoclopramide, the 10 or the 5. What is happening here? So are there alternatives? Is self-pay, cash pay less than the denial and going through a prior authorization? There's many options, and we want to look about that. What other routes are available? Maybe that, again, the pill they can't swallow comes in, you can get compounded into a topical cream, and that's going to be more affordable than what the insurance copay is. So lots of things as a pharmacist and our technicians, our staff, we know, share that information over a lifetime, at least over those 9 months, huge financial impact. And then when to taper off meds? You're going to see polypharmacy on all these moms. I haven't seen one antiemetic really give the benefit they need to get back to work and get their life living again. So when do they taper off medications? If you've been on one from the beginning, you've added drug 2, you've added drug 3, maybe drug 1 wasn't working, or maybe the adverse effects like doxylamine is making them sleep. Let's see, just have that conversation, see when's the right time to taper off, and see if your patient keeps coming back to the ER and coming back to the pharmacy and going to the ER and coming back to the pharmacy, have them talk to their insurance about setting up home health to avoid that in and out and disruptive lifestyle. They can't even get out of bed to go to the bathroom. They definitely don't want to be going to the emergency room, and they don't have the strength to go to the doctors to get prescription refills. So early intervention and treatment of these women that have mild and moderate symptoms may prevent the progression to severe disease. And they're going to be seeing you in those first few months more than anybody else. Now, if they do go into the hospital, this is how they're going to be assessed: nausea alone, vomiting with or without hypovolemia. And we're going to correct the hypovolemia, ketonuria, electrolytes to reduce the symptoms, increase the quality of life, and prevent these serious complications from happening. And as a pharmacist, we can minimize those adverse effects of pharmacological treatment. So this came from Up to Date. Love their guidelines to improve the physical, mental, and financial health. Pharmacists are in the perfect position. What does a treatment plan look like? This is my own treatment plan. We need to get them fluids. Water is the fundamental nutrient of life, right? If you can't drink water, what can we do? Your pharmacy, you have a lot of options just right in front of you. Can you get Pedialyte in? Can you get liquid IV? Does that even work? These are conversations that you need to be having with your patients. How do you get vitamins and electrolytes, right? We have lots of supplements that might help. Do you sell patches? Do you sell other things in your pharmacy that may or may not work? Have the conversations. Antiemetics, I'm going to jump into those in a moment. Then add antacids if needed, if the benefit outweighs the risk. Bowel regimen, please talk to every one of your pregnant moms about constipation. If they're constipated, you're going to have an increased risk of GERD, of reflux. You've got to get that GI tract moving to help ease these symptoms and not exacerbate them. And what other support is available around you or in your pharmacy? What's not a treatment plan? These are my own medical records. I am dating myself here. These are from before we had electronic health records for those young ones watching. So this is my daughter who's now 22, and I don't remember any of this. I just know I was in the hospital over and over and over. And if you look on the left here, it says encourage fluids. And on the right here, drink lots of fluids. Trust me, if I could have done that, I would not have been going back to the emergency room. So here are those two. Again, not a treatment plan. So that was 22 years ago. This is happening still today in the United States. On the left is a mom from California. Oh my gosh, just reached out to me for her help. I gave her some advice. She said, thank you, thank you, thank you. And of course I said, you're welcome. This is what she responded. I was diagnosed with six different hospitals, but only because I brought it up. I threw up so much, it caused a hematoma in my uterus, and I bleed so much. How terrifying is this for a mother? It should not have come to that. educate everybody you know on hyperemesis. Remember, we're talking over 75,000 women in the United States annually based on 2019 statistics. These doctors just don't understand. That women lose their teeth from this. Their organs start to fail. They end up dehydrated, malnourished. It's unbearable. 4 failed pokes this morning. This is I feel like these nurses trying to get IVs into these women when you're severely dehydrated. There's things we can do to help. Tell your mom if they're coming into into your pharmacy for medication refills, and you see that they're on IVs, they've been getting IVs, tell them, ask for some lidocaine cream, right? What about EMLA? There's things, tell them to ask the nurse to use an ultrasound scanner to find for that, a vein finder. These are available, but people don't know, nurses don't offer. You're in a position to share this advice to them. And on the right here, this is where I live in Las Vegas. This is a women's specialty OBGYN clinic. And I can't even read it because it is just triggering and unacceptable. If they do go to the emergency room, again, it's not for you, this audience today, but I just want to let you know it's the opposite of our sepsis patients. Best is lactated ringer because it has those electrolytes, but you want to infuse 2 liters over 3 to 5 hours, very, very slowly, because we want to prevent these shifts from happening. That's why we would use half normal saline. Want to prevent renal damage. It could send them into acute kidney disorder, too much, too fast, after prolonged dehydration and electrolyte deficiencies, prevent the osmotic demyelination syndrome. And remember my mom with glucose I talked about? If you are going to give glucose, she needed it, right? Well, she's going to use dextrose. If you need these sugars, and they need thiamine. Thiamine's very, very important for many reasons to prevent complications later in pregnancy. We want to just separate that thiamine from the dextrose or your glucose or whatever sugar they're getting. Vitamins, electrolytes, and others. So others, we talked about those lab tests. So many women today, especially pregnant women, are low iron. Have them look at their hemoglobin when they get a panel done of lab. They're already running the labs, right? So we're going to look at our electrolytes, calcium, glucose, iron. What else do they need? Do they have that baseline thyroid? Do they have a family history of thyroid? That's what we're going to look at other. How can you help them get electrolytes to keep them out of the emergency room? How are your nutrients, your vitamin section? Do they have sublingual formulations? Do they have liquid formulations? Could you say maybe put that in a smoothie, add a little protein powder? This is going to make a world of difference, even if they could just sip that to get them some of these nutrients. If they're low B12, could they handle a weekly injection of that to get those levels up? When we look at vitamins that are methylated, all of our B vitamins, folic acid, of course, we want that right away to get our heart and palate formed correctly. But it takes all these B vitamins. B6, of course, your pyridoxine is the one known to help with nausea. Studies are conflicting. That's why there's that combination that's been FDA approved for morning sickness. But it's not just one of these B vitamins alone that is going to bring that mom to the state where she can function. Okay, the meat and potatoes here of this session. Antiemetics. Literally, what medications are going to stop the mom from the severe vomiting? And I'm going to put this caveat out there. Very few actually help with nausea. So if you know of any, please reach out to me and please share it with the world. We're looking at medications that are going to be targeting different areas of the brain and of the body. And I added here the cannabinoid system because every day I have mom reaching out to me asking me, hey, can I use cannabis with or without THC? And that's a personal choice, conflicting evidence. But if you're with a mom who can't get out of bed, who's lost their job, considering termination, there might be an opportunity here until we get more studies that show it's safe and effective, or a certain brand or strain or dose is safe and effective. So we're looking at these different ways to treat this. I just put it all in one chart. I could do a whole hour talk on these different antiemetics, the different doses, really what you want to find here. If you go to the Her Foundation website, hyperemesis.org, I love their medication algorithm. Different hospitals have different medication algorithms just for hyperemesis gravidarum. I take a more personalized approach. I know many moms that started with antihistamine. It made them feel really horrible. They couldn't get out of bed in the morning. They don't want to sleep through their pregnancy. That's not healthy. I wouldn't start there. There's a reason it's always number 1 in the guidelines. That goes to extensive testing decades ago from a lawsuit that happened, manufacturer won, but stopped making it. Reformulated, repackaged it now as like Clegis, Bonjesta, extended release, less adverse effects. If insurance covers it, you're early in the pregnancy, give it a try. But what we're looking for here is what can they take down that's going to have the best effect with the least adverse effects that their insurance will cover. And if they fail these, then what can we do to get these other medications covered? For example, granisetron comes as a patch called Sancuso. It's never going to be a tier 1 formulary. Cash pay is $650 per patch. However, we get it covered for our chemotherapy patients, right? Can we get it covered for our pregnant women too? One patch stays on for 7 weeks. I've seen amazing responses. The biggest adverse effect I hear from these women, a few of them have reacted to the adhesive. Put some Benadryl on it, get that nausea under control. And like I said, you're going to have polypharmacy here. Which of these can you put together, one at a time, of course, to have the safest pregnancy? And then if that heart and palate is formed, go ahead and look over at your steroid section. This is one of the few that I've seen actually helps with nausea based on how it's changing the cellular structure, right? This of the cell. Prednisone, methylprednisolone, again, long-term high dose effects, probably you're going to have too many adverse effects. But short term, let's get it under control and decide how to taper off. Gabapentin's an interesting one. Dr. Thomas Guttoso started studying this one, found great effects coming from retail pharmacy. Not a fan of gabapentin, but these hyperemesis moms go to really, really, really high doses. Swear by it. It's up to you, the pharmacist's advice, the mom, the patient, to decide when should we taper off this. Is there anything that's going to affect the baby? I'm seeing great results here, but want to see more. And just tell these moms that there are options, because so many clinicians just don't know. They tell their mom, we've tried everything we can. Here on the top left, Remeron, right? Mirtazapine. I've seen great results from this as well. Help them sleep through the night. That one is oral though, of course. So we're looking for rectal, topicals, patches. If you work with a compounding pharmacy, go ahead and reach out to them, see what they can do, how you can partner. And Home Health offers subcutaneous pumps. Not all pumps are equal, though. These are my own pharmacogenetics. Cannot do this presentation without talking about personalized medicine. Folic acid, I do not metabolize my synthetic folic acid the way it needs to be to get L-methylfolate. What do you have on your shelf for prenatal vitamins that has L-methylfolate? You'll see it there now. Ondansetron, labs are not allowed to say things like this anymore, but due to increased likelihood of nausea and vomiting, use caution. I don't think the med actually increases it, but I have this P-glycoprotein, the ABCB1 gene. It's not getting to the serotonin in my gut. It's not going to help me. However, Aloxi, palansitron is, and I don't know how I'd get an insurance company to cover that one, but if I were ever to get pregnant, it is my drug of choice. Have to talk about Zofran safety. So many studies out there scaring these women. I'm going to tell you, all the latest studies show it is not a teratogen. I'm going to say it again. It is not a teratogen. We have this. However, there are high risk adverse effects potentially on the mom. We're going to get that QT prolongation in a mom with either a family history, potentially, or electrolyte imbalances, or in combination with other medications that could cause QT prolongation. I tell that mom, if they're getting it in the hospital, have them do that EKG and see what their QT is. Talk to them about constipation. I've met moms, they end up in the emergency room with impacted stools. Just what that does to your self-esteem, I can't even fathom. So get them on that bowel regimen and talk to them. Just keep an eye out for that serotonin syndrome. Cannabis, they come into your pharmacy, they're admitting they're using cannabis. Do you have drug testing kits who can access the result? Know your state laws, because they're afraid to tell the doctors in the emergency room they're using this in many states where it is not legal. Keep that in mind. Antacid, risk versus benefit. Famotidine, if you're getting vomiting blood, you're at risk for esophageal erosion, those ulcers happening, right time. But tell these moms the least amount of time for the least of the dose for the least amount of time possible. And once that baby is born, you're recovering, get off those antacids. I always recommend digestive support. We have so many probiotics, digestive enzymes, papaya enzymes are in your pharmacy. Nice recommendations that are going to have more benefit than a risk of adverse effects. And I talked about this bowel regimen. If they're dehydrated, stay away from fiber. It's going to cause a lot of pain. Talk to them about where is the constipation happening? Is it higher in the GI tract? Is it at the bottom end of the GI tract? And then choose what's available there. Magnesium comes in so many forms. Do you have a magnesium oxide? Do you have a triple magnesium? Do you have a spray? Do you have Epsom salts? Even a bath in that can absorb some magnesium. So definitely make these recommendations. Some little pearls: avoid scopolamine in these preeclampsia patients or those with severe dehydration and electrolyte imbalances. However, for those with excessive saliva, scopolamine is a great choice. Robinol is another one, your glycopyrrolate. Watch for drug-drug interactions, muscle wasting, dopaminergic effects, your extrapyramidal symptoms. The moms that see these obstetricians who are being prescribed antipsychotics as antiemetics, you're looking at compazine, right? We have a few others, olanzapine. I have them on the earlier slide. The OBs are not trained in the long-term effects like psychiatrists are. But if a patient does end up seeing a psychiatrist or does prior to becoming pregnant, they're going to say, do what your OB says when it comes to medications. OBs are going to say, do what your psychiatrist says, maybe not. Or they're just going to prescribe everyone the same med. When they're using this for antiemetics, if that mom goes home and Googles, what is that med, and sees it in antipsychotic, they're going to get scared. So all things to talk about. Antiemetics, better scheduled, not PRN. We want to get that patient to steady state so they're not starting over. And when it comes to pumps, I've come from retail pharmacy, hospital pharmacy, consulting pharmacy, did not know pumps are a thing. This mom posted, is this normal? No, there are mini pumps out there. There are different types of pumps, and it's going to get that steady state sub-Q. Let's get the mom on the right pump so this doesn't happen, and make sure they know how to get the alcohol rubs, keep a clean, sterile environment so that these injections don't get infected, anything with a line. And benzodiazepines might benefit really tremendously. We just don't want a mom long-term on benzos through their pregnancy. But if they're going to their ER over and over and over, one dose of that, please just explain to the mom, doctor prescribed this for you, give it a try. One dose, right? Let's see the positive might have a world of difference. And more clinical pearls. CGMs, please talk about continuous glucose meters for these women, either the ones that were heading into the pregnancy at risk for diabetes, diabetic, or the ones with hyperemesis cannot do the glucose test, the gestational diabetes test. It's impossible to keep glucola down. Tell them, recommend this. This is being shown now at the obstetric conferences as well. So really, really support these patients. A few more clinical pearls, and mental health is such a big component of this. Watch out for those antipsychotics being used as antiemetics. Watch for the extrapyramidal symptoms. There is a scale that can be used called AIMS, mental health evaluations. I'm telling you, if any one of these women go to the emergency room, they're giving a mental health evaluation, their score is going to be off the charts. Have them advocate for themselves. Bring an advocate. You want to treat the cause, not the symptoms, and get them those referrals that are appropriate, but not the ones for mental health hospitals. That is not the root cause here. They need nutrition. Have them get a referral to dietary. They might need a PICC line, enteral or going to a PICC line. And the most important thing for me to convey to you is train all your staff to have empathy for these patients. Don't compare it to your own pregnancy, and don't say common phrases. Yes, they've tried crackers, they've tried ginger, they've been on a brat diet. That does not work. They are here because it's a serious medical condition that can lead to severe complications, including mortality. And stay away from phrases on the bottom left. This ultrasound technician told this mom she would never take medications because it could cause birth defects. Can you imagine what it would do? This mom just can't stop crying. Stress is going to increase that GDF15 gene, which is going to increase the excessive vomiting. We want to stop that cycle and have empathy. So what happened to our three women? Maria did not make it. She was at a well-renowned hospital system in the United States and was not believed. The Her Foundation, I did not work with her personally. The Her Foundation did, and started this campaign called the One Mom Campaign to share her story. So women like Maria are believed she lost her life and that of her twins. Please go to this website, hyperemesis.org/onemom, to learn more about that. Elise did survive. She became a very outspoken advocate on how to properly treat hyperemesis patients. She was a nurse, and you can see on the picture at 9 months, there wasn't much left of her. It's unbelievable. She did go on to have another pregnancy with a care plan in place, and is recovering from still today with the effect it has of long-standing malnutrition. And you can read her story and advice on Medium. And on the right, remember I talked about my pregnancy back 22 years ago? I survived. I had what we thought at the time was good care. I know better now, but at least I could go to an ER. I could get IVs. They tried. I'm okay. Today, all these decades later, Jessica Cronshaw passed away this past winter in the UK. Please go to her fundraising site, share these stories are still happening. Women are being medically gaslighted, not taken seriously. This is a real medical disease. So just a couple of key points: tell them the name of their disease. We want to reduce their emesis, replenish their electrolytes, and keep them out of the hospital, get prompt treatment to prevent these morbidity and mortality. So thank you so much for taking time to listen to me today. I do have a freebie. I asked my followers when I was going to speak, before I was going to speak at an emergency medicine conference, what do you want the ER to know? And within 24 hours, woke up to over 100 responses. I thought I was going to have a little handout. It turned into a 22-page book. It's free. If you want a hard copy, reach out to me, connect with me on LinkedIn. I'm here to support all the clinicians and all the patients so that women with this extreme vomiting in pregnancy are taken seriously and never left alone and never left to suffer. So thank you for doing your part as a retail pharmacist. Again, thank you. Have a great day.